Next, there's a subarachnoid hemorrhage, which is bleeding between the arachnoid mater and pia mater, the innermost layer of the meninges. In general, the most common cause of subarachnoid hemorrhage is head trauma, while the most common cause of a spontaneous subarachnoid hemorrhage is the rupture of an aneurysm. Aneurysms can burst open when there is an increase in intracranial pressure. The most common aneurysms in the brain are saccular cerebral aneurysms, also called baryaneurysms. They typically arise in the anterior half of the circle of Willis at bifurcations. Bifurcations are junctions between arteries, and the most common junction where saccular aneurysms take place is between the anterior communicating artery and the anterior cerebral artery. Some genetic disorders like autosomal dominant polycystic kidney disease, Marfan syndrome, and Ehlers-Danlos syndrome can predispose even young individuals to saccular aneurysms, and that's a fact that gets frequently tested on the exams. And a less frequent cause of a spontaneous subarachnoid hemorrhage is an arteriovenous malformation, which are formed by abnormal tangled blood vessels that aren't used to high arterial pressures and can rupture easily. In most cases, subarachnoid hemorrhage progresses rapidly due to arterial bleeding, and individuals complain of an excruciating headache, also known as thunderclap headaches, that are described as the worst headache of my life. There can also be nuchal rigidity, seizures, and symptoms of increased intracranial pressure like vomiting, vision changes, and confusion. The diagnosis of a subarachnoid hemorrhage is usually made with brain imaging. In most cases, this is done with a CT scan. Brain imaging shows blood in the ventricular cisterns, interhemispheric fissures, and within the sulci. The more blood that's seen, the worse the outcome. Now, in cases of spontaneous subarachnoid hemorrhage, if the brain imaging is negative, then the diagnosis can be made with a lumbar puncture and cerebrospinal fluid analysis. When there is spontaneous subarachnoid hemorrhage, the test will show red blood cells or xanthochromia, which is a result of red blood cell breakdown. In the case of a traumatic subarachnoid hemorrhage, a lumbar puncture is contraindicated due to the high intracranial pressure and the risk of brain herniation. Initial management of a subarachnoid hemorrhage is supportive, but rebleeding is very frequent, so the only effective treatment is prompt surgery like aneurysm repair. A complication that can occur about 2 days to 2 weeks after a subarachnoid hemorrhage is post-traumatic vasospasm of the subarachnoid vessels, which can cause cerebral ischemia. Therefore, individuals are given a calcium channel blocker called nimodipine, which relaxes the cerebral vascular smooth muscle, preventing vasospasm. Another potential complication is hydrocephalus, which can lead to increased intracranial pressure. This can present with progressive deterioration in level of consciousness, and ventricular dilation can be seen on CT scan. Some individuals with a subarachnoid hemorrhage develop electrolyte imbalances like hyponatremia due to water retention. This can result from one of three things: the syndrome of inappropriate secretion of antidiuretic hormone, or SIADH, cerebral salt wasting caused by excessive secretion of natriuretic peptides, or diminished central sympathetic activity. Other common complications of a subarachnoid hemorrhage are fever of infectious or non-infectious origin and seizures.